morning and welcome to today's webinar sponsored by the Education Subcommittee of the American Thoracic Society's Assembly on Sleep and Respiratory Neurobiology. I'd like to thank our listeners for joining us. This webinar today is entitled Decoding the Data, Introduction to Critical Appraisal in Healthcare Research. We will discuss how clinicians and aspiring scientists can systematically evaluate research works to develop an informed assessment of the strengths, limitations, and overall value of the research study. I'm Dr. Melissa Maloney, Assistant Professor of Pediatrics at the University of Utah and Associate Program Director of the University of Utah Sleep Medicine Fellowship Program. And I'm chair of the Sleep and Respiratory Neurobiology Education Committee. Joining me is my co-moderator and Education Committee co-chair, Dr. Sonal Malhotra. Sonal is an assistant professor of pulmonary and sleep medicine services at Baylor College of Medicine, as well as an associate program director of their sleep medicine fellowship program.
Thank you, Melissa, for the introduction. I would like to go ahead and introduce our esteemed speakers. Starting with Dr. Jeremy Orr, is an associate professor of medicine in University of California, San Diego. His research interest is in non-invasive ventilation, sleep apnea, and breathing issues in patients with chronic lung, heart, and neuromuscular conditions. Next, we have Dr. Sanjay Patel, is a professor of medicine, epidemiology, and clinical and translational science. He is also the director of the Center for Sleep and Cardiovascular Outcome Research and the medical director of the University of Pittsburgh Medical Center Comprehensive Sleep Disorder Program. His research focus is on understanding the epidemiology of sleep disorders with particular emphasis on chronic partial sleep deprivation and obstructive sleep apnea and potential effects of these disorders on metabolism. And lastly, we have Dr. Neomi Shah, is a professor of medicine at Icahn School of Medicine at Mount Sinai. She also serves as the Associate Dean for Faculty Career Advancement and the System Vice Chair for Faculty Affairs in the Department of Medicine. Her research focus is on understanding the complex relationship between obstructive sleep apnea and cardiovascular disease.
So today our webinar format will consist of a 15-minute presentation by each of our speakers, followed by a brief question and answer portion after each of the speakers. When all three of our panelists are finished, we'll open the floor to questions from the audience. Throughout this presentation, you're encouraged to use the Zoom chat to ask any questions or put in any comments for discussion. This webinar will be recorded and posted on the ATS website for later viewing, and a link to view the webinar will be sent to all registrants. And with that, I'd like to turn it over to Dr. Orr, who will be talking about study design and strengths and limitations of various types of study design.
Great, thank you. Let me share my screen. Okay, hopefully everybody can see that okay. Nice to be here amongst some esteemed folks, and I'm going to try to talk a bit about study design. Obviously, this is a short session, so I think we're going to hopefully give a broad overview, and if there are questions that are burning questions, I think that'd be helpful to hear about. So when I'm approaching a study, I think the first thing that I try to ask myself is, or try to intuit, is what is the objective of the study? And when you're designing studies, obviously this is something that's really important. But when you're interpreting the study, you have to really try to understand what the person is trying to convey, what they're trying to investigate. And most often in research, the goal is to understand the impact of an exposure on an outcome. So in other words, what you're trying to understand is a cause-effect relationship. If you do something, what will happen? And one thing that's been called a sort of causal inference. So trying to understand the causal order of the world. And there are people that, study this. In particular, somebody that, if you want to read in detail about this, Judea Pearl at UCLA, who talks about this ladder of causality. And so the idea is that, when you're looking at data, that, sort of different levels of causality and causal claims that you can make. And so the lowest level, or the sort of the easiest claim to make, is some claim of association or prediction. So, this factor is related to some other factor. And you're not really making any claim that if you, have a effect on factor X, that it's going to change factor Y, but you just say that there's an association there. The next level is where you start getting more causal, and you start saying you're making comparisons. If you compare this group that received, this treatment to the group that didn't receive the treatment, that the group that received the treatment had a difference in outcomes. And so a lot of times that's where a lot of our research lies, is sort of being able to make comparisons between groups, different exposures, different treatments. The highest level of causality is sort of what we do on a day-to-day basis when we're walking around the world. We intuit counterfactuals. So, in other words, this is the idea of what would happen if you did or didn't do something. So it's sort of these theoreticals. And when we're looking at something, we see something, a lot of times we can sort of understand the order of the world in this way. But in research, it's quite difficult to actually look at counterfactuals, although people are really trying to delve into this and try to understand, for example, for individual patients, if you did this treatment or didn't do this treatment, what would be the outcome? But this is really challenging. So again, I think most of the time in clinical research, we're on the level of, association or comparison. And again, an example of this is for an association would be like developing a risk score. If you're trying to develop a risk score for obstructive sleep apnea, for example, you might put a bunch of different things in the model to develop a risk score, but you're not necessarily saying that that is a cause-effect relationship, that if you change one of those factors, that you reduce the risk of sleep apnea. The comparison level would be the effective intervention. If you give a CPAP machine to somebody, does that reduce some symptoms? So really, again, most of the time we're trying to look at causal relationships. It's the most relevant, thing that we're trying to do. And every study, the reason I mention this is that every study, when you're designing the study, it needs to address issues with confounding or bias in the study design. And that's really the major challenge about study design, is how do you know that the effect that you're looking at, the treatment effect on the outcome, is a causal effect and not related to confounding. And so this is what drives decisions about study design to an extent. The other thing I'll mention is that some studies are more mechanistic and some studies are more clinical, and some do a bit of both. But I think it is important to try to understand, is this study trying to look at mechanisms or clinical outcomes or clinical interventions? So, you're trying to understand the effect of sleep apnea on neurocognitive outcomes, or you're trying to understand, if you give some people a CPAP machine, will that change neurocognitive outcomes? Those are sort of different questions, and you can't always answer both in a single study. The next thing I sort of ask myself is I try to understand, why was the study design chosen? And the choice of study design reflects a number of factors. And maybe first, I just mentioned sort of the sociology of science, for lack of a better term. Like, why are we asking these questions in the first place? And there's kind of two things I'll mention about that. One is, sometimes it's about, what people's motives are, right? So if it's a pharmaceutical study, their motives might be quite different than an investigator-initiated study. I'm not saying that it's wrong, but that might influence why they chose to design and do the study in the way that they did. The other thing is just, our broad ideas about what's going on. And so, we ask questions based on sort of hypotheses, and those come from the greater context of what we know about things. So I try to think about that a little bit. Study design comes down to resources. So, most of these things cost money, some more than others. Most of these things require expertise, and in different institutions, different places, you're going to have expertise in different techniques. And then time. Some things are urgent, like when we had COVID. There were a bunch of studies that came out because we had nothing and we needed something. So time is a factor. It may come down to the time of we have like fellows who are working on projects, and they only have a certain amount of time, and that informs what they do. Data outcomes or availability, that obviously is a big factor. So is this something that we already have existing data on that we think we can utilize? Is this an outcome that you can realistically measure? If you want to measure, effective sleep apnea, and the outcomes are 30 years, down the line, in terms of survival, that might be a little bit difficult. And then ethics, you can't do randomized trials and everything, and you can't even do observational studies and everything. And the very classic example of this, right, is the Tuskegee syphilis experiments where they monitored people that had known syphilis infection instead of treating them. And so ethics obviously play a big role. You're not going to randomize people to cigarette smoking. So these things are important when we're thinking about why the study was done in the way it was. So just to jump in, randomized controlled trials are often considered the gold standard. There are a lot of different types of randomized controlled trials. And the most common design probably is a parallel group randomized controlled trial. It's sort of shown here where you take individuals and you kind of roll the virtual dice and assign them to one of two potential groups, and then they go on and then you measure outcomes. Sometimes randomization is done in a clustered fashion. So instead of randomizing individuals, you might randomize groups of people based on some natural clustering. Like you randomize one hospital, a group of hospitals to one thing, and one group of hospitals to another. There's these different other things where you do, there's a stepped wedge where you sort of gradually start adding randomization in. And then there's these factorial designs where maybe you have two interventions that you think are important. And the reason that you want to test them together is that you think there could be an interaction between the two things. So, for example, if you want to give somebody tirzepatide for sleep apnea, and the other option is CPAP, and you might want to consider, well, what about tirzepatide plus CPAP? There may be an interaction between those two things. So a factorial trial where you're putting people into 4 different groups to study 2 different interventions can be a good one. Crossover trials are also really common. So that's where each person does see both treatment condition. If one group starts one condition first, then crosses over, the other group does the other condition, then crosses over. Very good study design because it eliminates variability across individuals. There's some issues with carryover effects and order of treatments and things like that, but obviously it doesn't work for mortality outcomes. Randomized controlled trials beyond this design, there's lots of other details. So blinding, was the investigator blinded? Was the subject blinded? Those things can vary. The control group. So was this a placebo-controlled trial? Was it sham controlled if you're talking about CPAP? Or was it, sort of usual care? Stratification is another factor. So if you have a factor that you think really strongly influences the outcome and you don't want there to be imbalances in the groups that are randomized, you might stratify the randomization on that factor. So male versus female, for example. Allocation, so 2-to-1 randomization it might make the study appealing for people that don't want to be in an untreated control group. And then there's superiority versus non-inferiority studies, and there's interim analyses and adaptive design. So again, all these things that you have to decide on. Randomized trials are not for every question. The benefit is that it limits confounding. You're randomizing people, so that's independent of any sort of confounding factor, but doesn't completely guarantee elimination just because there are things that can happen in a randomization or an unmasking, things like that. But the limitations are it's resource intensive. It's very hard to run a randomized controlled trial. It takes a lot of time and money and personnel. As a result, a lot of studies are underpowered. They don't achieve the power to detect the outcome if they wanted to. They might not enroll as well as they wanted to. There are a lot of ways to mess up a randomized controlled trial and make the trial negative or even positive, but you can mess it up in a lot of ways. There's heterogeneity of treatment effect, which I think Dr. Shah is going to probably talk about a little bit. That you get an average effect of the treatment, but the response across different individuals may be different, and it can be hard to sort of determine that. And then maybe the last one, again, this gets into a bit of interpretation that participants might not reflect the patients that you care about. Other prospective interventional designs, so sometimes called quasi-experimental designs, are single-arm studies without a control group where you measure pre and post within an individual. But time and learning effects can be a factor there. You can use a single-arm study and use an external control group. So you could, for example, use historical controls, but the control group might not be super relevant to a more modern control group. Then there's pre and post studies where maybe you have you monitor stuff for a while and then you implement an intervention. This happens a lot in intensive care units, for example, and then look at what happens subsequently, often using these time series analyses, which are really powerful techniques, but lots of different ways to sort of model the time effects of data and then report the actual effect of the intervention. Observational studies are probably the most common types of studies, but they're extremely variable in design. You have cohort studies where you have a group of patients followed over time. You have cross-sectional studies where you look at people in a single point in time. Case control studies are really interesting. You might find a rare outcome, find cases, and then match them to people that didn't have that outcome. And you can compare those groups. And all of these studies can really be done in a prospective or retrospective fashion. So if it's retrospective, it might have been existing data in an electronic medical record, and that might, the available data might just depend on what was previously collected. Prospective studies, you might say, this is the question we want to ask. We're going to design this and we're going to run this study for a while and make sure that we get all the variables that we want. For example, the sleep heart health study would be an example of that. But then, going along with this, there's primary versus secondary analyses. So even in a prospective study, you might say, well, we want to measure this, we're looking at sleep heart health, but we collect this rich data set and there may be other questions that you can answer with that data, although we have to recognize that maybe it wasn't originally designed to answer all of those questions. And again, the major challenge for observational studies is addressing issues with bias and then particularly confounding, that you're not randomly assigning people to an intervention, so people may not be equivalent. And so this is sort of a classic one that you could find an association between yellow fingernails and lung cancer, but of course it's confounded by smoking, that people who smoke get yellow fingernails, people that smoke get lung cancer, and there's no actual relationship between yellow fingernails and lung cancer. So if you didn't measure smoking, you'd be led astray. There's issues like differential loss to follow-up, so people in one group might not have the same follow-up as another group. One that I want you to just stick into your head is something called immortal time bias. This plagues retrospective cohort studies, that people who receive an intervention are not at risk for a mortality outcome while they've received that intervention if you condition on it. And so those people often always have greater survival. Anyway, you can dig into that. It's going to be a whole course on immortal time bias. There are methods for reducing bias. You can do matching. You can use adjustment. There's more modern techniques with this target trial emulation and instrumental variables to try to reduce these issues with confounding and bias. And so I pay attention to that when I'm reading these method sections, how they addressed issues with bias and confounding. And then I'll just mention meta-analysis. So this attempts to take all these prior studies and then synthesize them. And it's often done as part of a systematic literature review where you go through and make sure that you haven't missed any studies and collect all that data. Some of them are done with just taking the averages and the standard deviations and kind of putting those together. But if you want to get a little bit more granular, you can get individual participant data and put that all together. It's a lot more work, but it gives you maybe a bit better of an estimate. And network meta-analysis is a really interesting design because you can take a bunch of different studies that compare different outcomes or different treatments, and you can look at those relationships, and then you can kind of make comparisons that weren't directly compared before. So this was a publication in The Lancet a few years ago that looked at different sleep aids, and they were able to make comparisons between lemborexant, for example, and suvorexant by nature of the fact that they had comparisons between lemborexant and placebo and suvorexant and placebo. So quite interesting. You can use these to aggregate underpowered studies and again, make novel comparisons, but there are big limitations here. One is that basically you're just taking this group of studies and getting the average. You're just, it's a big averaged treatment effect. And so again, it's not speaking to that third rung of the causal ladder. It's just speaking to, the average effect across all individuals. of treatment, and that might not be as relevant for some patients. And then it doesn't fix issues with the studies that were included, sort of garbage in, garbage out. If you have biased studies that go in to a meta-analysis, you're going to get a biased estimate on the way out. So study design takeaways. Study designs are highly variable and influenced by a lot of different factors. There's no perfect study design. And really, I think the goal when you're looking at study design in literature is to understand the details so that you can accurately interpret. And the goal here is not just to, be critical and say, oh, this study's terrible and that study's great stuff. It's really to look at these studies and figure out the strengths and weaknesses and see if you can learn something from every single study. And I'll just leave with that slide and try not to do this. Okay, thanks so much.
Thank you, Jeremy. In the interest of time, we're going to go ahead and move on to Dr. Patel, who is going to talk about how non-scientists or early scientists can assess the methodological rigor of a paper's statistical analysis and data reporting. I am going to be sharing Dr. Patel's slides. Go ahead, Dr. Patel.
Thanks so much, Melissa. Why don't you just move on to the next slide? So this is just kind of what I would call maybe the idiot's guide to how to assess the statistics of a paper. And, it's just sort of the quick and easy way to try to do things. It's just assessing who are the authors, how good is the journal, do the unadjusted results match the results of the full statistical models? And if there's unfamiliar statistics that are being used, do the authors explain why? And so hopefully, even with minimal statistical background, any physician can kind of assess the paper they're reading and get a sense of whether they believe how the results were analyzed. Next slide. So in terms of looking at the authors, what I mean by that is to assess whether there's a statistician as part of the study team. So higher quality research studies are going to have a statistician perform the statistical analyses and include that person as a co-author. If you don't have a statistician helping you, that often means that you're not only the statistics, but also just the data management was not done very well. It was just some residents collected stuff in Excel sheet, and there's high likelihood that they messed things up. Or most peer-reviewed funded science, if you try to apply for grant funding, the review panel is going to demand that there's an experienced statistician on the team to ensure appropriate methodological rigor. And so it makes sense that that statistician who was on the team is included as a co-author on the publication. The last point is that unlike the other authors, the statistician typically doesn't have a strong personal bias about the outcome of the study. So, I'm going to pick on Neomi. She spent her career trying to prove that sleep apnea is an important cardiovascular risk factor. And so she has an inherent bias, as do Jeremy or I or others, to try to say sleep apnea is important. The statistician that I work with, though, doesn't have that bias, right? They could work with on many different studies. And so having that statistician willing to put their name as a co-author provides reassurance that that there is adequate methodological rigor, that the statistician is agreeing with the results. Next slide. So the second point is just relying on the journal. As most of you probably know, higher quality journals perform more robust statistical reviews. And it's important to recognize that most journals these days have some sort of statistical review process, but whether that review process is an actual statistician or just, a scientist who has done a lot of statistics differs from journal to journal. And then whether or not the journal actually pays their statistical reviewers really varies. And the higher quality, higher impact factor journals really pay statistical reviewers, and that you get what you pay for, right? So you're going to get better quality reviews than one that just kind of signs up junior faculty to be a volunteer reviewer. The only caveat to all of that is it's important to just assess whether the type of research that you're reading in that paper is typical for that journal. In other words, do they have appropriate statistical reviewers in-house for the type of paper that you're reading? So, just like there's many different subfields in medicine, there's tons of subcategories of statistics. And a statistical geneticist may not be the best person to do a good review of a randomized trial. And similarly, a clinical trialist isn't going to do a great job reviewing a genetic epidemiology paper. So Jeremy's already gone through some of this. I'm not going to talk about qualitative research because that really doesn't include a lot of statistics, but from a quantitative research standpoint, there's really two main goals. One is predictive modeling, building a model to predict X in a cheaper, simpler, or more timely way than the current gold standard, versus the causal inference, where your goal is to try to demonstrate that A causes or prevents B. Next slide. So we're talking about predictive modeling. The approach to building the statistical model doesn't matter a lot. Since you don't really care about the nature of the relationships, the strategy is typically to throw everything in the model and then see what is predictive. So people can use stepwise regression, consider nonlinear terms, interaction terms. More advanced strategies use these classification trees, neural networks, machine learning, artificial intelligence, anything under the sun. Next slide. What's really important is how you evaluate the performance of the model. So it's important to recognize that you can't simultaneously create a model and then test how well it works in the same data set. That's called a winner's curse. Just in trying to find the best model, there's going to be some random noise that's going to make the best model perform better in that data set than it would have been in. And so you can't get an unbiased measure in the same data set. So you have to test the model's performance in an independent data set to get an unbiased estimate of performance. So that's an important question to ask as you're reading a paper is, did they test the performance in an independent data set? The second thing to just recognize is that in general, the goal is not to demonstrate that you have some arbitrarily high performance, high C statistic or AIC or whatever, but it's really to test the hypothesis that the new model that you've created performs better than the current standard. So what you'd ideally like to see is some hypothesis that's being tested where the new model's tested against some current standard and you can accept or reject that hypothesis using sort of standard statistics. Sorry, next slide. So moving on to causal inference research, again, Jeremy hit on a key point in observational research is trying to determine the causal association between the exposure and outcome, recognizing that sort of the gross association you see may be biased by confounders. Again, it's important to just recognize that biologically confounders are almost always positive. They're associated in a positive way with both the exposure and the outcome, so that when you account for them, it will lead to weakening of the effect estimate. If you see, well, we'll talk about it, but if you see the opposite, that should raise some red flags. With randomized trials, again, the whole point of doing a randomized trial is that you're assigning the exposure at random so that there's no association between the exposure and any confounders. So there, in general, is not any need to adjust for confounders. Next slide. So how do you identify confounders? Again, Jeremy hit on this. The key thing is that you should identify them based on biological knowledge and prior literature of your understanding of the causal relationships. What you shouldn't do is use statistics to pick confounders. So they shouldn't be based on, an association meeting some p-value threshold, using some sort of regression method based on model fit or based on change in the beta or the effect estimate when you include it versus not including it. Those statistics don't really get at causality, so they're not appropriate. Next slide. So the key really if you're not an active scientist and you're just trying to be an active reader of the scientific literature, is to just have some basic familiarity with basic statistics. And I think these are sort of the basic things you should be familiar with. If you're comparing sort of continuous outcomes, you really want to compare the means with the t-test. If you're going to adjust for things, then you'd use linear regression. You're looking at a categorical outcome, and you're going to compare proportions with that outcome between groups using a chi-squared test. If you're going to adjust for things, then you would be using logistic regression. And then for survival analysis or time to event analysis, the basic unadjusted method to use is comparing Kaplan-Meier curves with the log rank test. And then again, if you're going to adjust for confounders, you'd be using typically a Cox proportional hazards model. So those are the basic statistics that I think most people should be familiar with, because those are going to be the most common things you're going to see in the literature. Next slide. So what are the things that should raise red flags for you? I think a key thing is just multiple hypothesis testing, right? And that's because testing multiple hypotheses inflates the risk of a false positive finding. So if the authors are building multiple models with covariates that don't make a whole lot of sense, and then choosing the model to report on that's positive, that gives you a positive outcome, that should raise some red flags. If they're testing multiple outcomes and then only reporting on those that are positive, again, often in the abstract, they might highlight the positive one, and then when you read the paper, you see they tested, 18 different things. That should raise some red flags. And then, especially with randomized trials, if they're continuing to increase the sample size until they get positive results, again, that should raise a red flag. Next slide. So with randomized trials, there's two main analyses that people perform: an intention to treat analysis and a per protocol analysis. And it's important to understand the pros and cons of these. The intention to treat analysis, you include everyone who is randomized, whether or not they ever got the assigned treatment. And so this analysis really tests the strategy of prescribing A versus prescribing B is better. These results are unbiased because, again, it maintains that randomization. You're assigning everyone based on what they were randomized to. Because people who are randomized to A may not get A in this analysis, in general, it provides a conservative estimate of the treatment effect, but it is providing a robust estimate of the prescription effect, which is, I think, what most physicians care about is, what should I do? What I do is I prescribe something. Whether or not the patient actually takes it is kind of up to them. In contrast, the per protocol analysis includes everyone who is randomized and received the treatment they were randomized to. So this analysis tests whether receiving A versus B is better, and it's really what you got rather than what you were randomized to. And because what you got may not be what you were randomized to, there's a large potential for bias, and that typically people who follow directions are very different from people who don't. So if I assign someone to get treatment A, but they decide they're going to get treatment B instead, that type of person has very different outcomes. And there's lots of studies showing that if you look at the outcomes of people who are randomized to placebo, whether or not they stayed with the placebo, whether they were adherent to placebo, has huge effects on outcomes. And so this provides an optimistic estimate of treatment effect. This is sort of a best case scenario, and is potentially open to bias that tends to favor the active treatment. So in general, the intention to treat analysis is the analysis that you want to focus your attention on from a rigor standpoint. Next slide. Another point is that if you've got two arms in a randomized trial, the primary analysis should be a comparison between the arms, right? Between treatment analysis. If you focus on within arm effects, you're really devaluing the whole RCT study design. In particular, if you show an outcome is significantly improved in arm A, but didn't significantly improve in arm B, that is not the same thing as showing that A is better than B. I often have authors who try to convince you of this latter thing because the between treatment analysis was not significant. And you just need to be careful that you don't fall for that. Next slide. With RCTs, it's really important that you go to where the trial was pre-registered. Again, these days, all randomized trials need to be pre-registered if they're going to be published in a reputable journal. Just about every journal demands that they be pre-registered. And so you should just compare what the authors report in the paper with what they claimed they were going to do when they pre-registered. It's amazing how many times people try to change what they did in the paper to try to make it a positive result. And when you go back and look at clinicaltrials.gov, you see what they had originally proposed was a different outcome or a different sample size. If changes have been made, the author should provide a good reason for why the change was made, and then you could assess whether that was reasonable. We've seen a lot of studies in the last few years where the sample size is much smaller, and the authors explain that they didn't meet their a priori sample size because of the COVID pandemic. And I think that's a reasonable thing, and that's not a sort of, I decided to stop the study early so I could report a positive result. Next slide. It's important to think about missing data. The first thing to recognize is data missing at random doesn't impact the validity of results. The problem is that data that's not missing at random can produce substantial bias, and concern for bias grows if that missing data rate is more than 10 or 15%. If there is substantial missing data, you want to make sure the authors have done something robust to try to minimize the bias. So methods like multiple imputation or last value carried forward have been proven to be less biased than simply throwing out people that have missing data. Just throwing those people out causes substantial bias. You can also do sensitivity analyses where you assume a worst case scenario. So for example, if you're missing CPAP adherence, you would assume that it's 0. If you have people who are lost to follow-up, you can assume worst case scenario that they had the worst outcome, like they died. And then you rerun the analysis. And if you get similar results, that can help reassure that the results are robust. Next slide. It's important to recognize that you shouldn't focus on the p-values alone. The p-values are limited because they are a function of power, which means they're a function of the sample size and the variance. And also people tend to use them to create a false dichotomy where a p-value of 0.049 is significant while 0.051 means there's no effect. That's really an oversimplification of what happens in the real world. And so it's, you want to combine looking at the p-value along with looking at the effect estimate, along with the measure of precision, like the 95% confidence interval. And ideally, in any abstract summarizing the results, the authors give you the effect estimate, the confidence interval, and the p-value. Next slide. It's really important to recognize the impact of large data sets. So as you increase the sample size more and more, you reduce random error, and that improves precision. Your 95% confidence interval gets smaller. What it doesn't do, though, is reduce systematic error. And so it doesn't improve accuracy. And this is something I think a lot of people don't recognize, that just because you have 10 million people, it doesn't mean your results are more accurate. In fact, typically with larger sample sizes, you're less able to collect all the key variables you may need, or at least collect them with as much, as carefully as you'd like. So you may not have all the potential confounders you wanted. And as a result, accuracy may actually decrease as you get into larger and larger sample sizes. Next slide. So significance can mean two different things. It can mean statistical significance and clinical significance. And it's important to recognize when the authors say something significant that you are paying attention to what they mean by that. So again, statistical significance, generally people mean a p-value less than 0.05, which means the chances of getting the findings they did or something more extreme would occur less than 5% of the time if there truly was no difference under the null hypothesis. In contrast, clinical significance is asking, is the effect large enough that patients and clinicians would be interested? And this is something that you have to assess as a clinician on, is this difference important enough that I would change my practice? So in general, the goal in biomedical research is to find clinically significant results, not statistically significant results. Now, we want study designs that are robust enough that they also are statistically significant to give us some confidence that it's not random noise. Next slide. So take-home messages, again, use easy surrogate markers like the authors in the journal to quickly assess statistical robustness. Look at the unadjusted data. Is there a signal there? If there isn't, that should raise some red flags. Focus on the effect size. Is it clinically significant? Does the statistical plan and confounders included make sense from your understanding of the disease? Is there evidence of multiple hypothesis testing? And if there's substantial missing data, is there a robust approach that was used to handle this issue? All right.
All right, I'm going to stop sharing so Dr. Shah can share her slides. And just as a reminder, continue to put any questions that you may have into the chat. And at the end, we will have time for questions for all of our panelists.
So let me know when you guys can see my slides.
Good to share.
All right, great. So thanks so much for having me. Great talks, Jeremy and Sanjay. I learned a lot, and sort of just understanding, you know, how folks are thinking about this landscape and sort of evolving, and especially how associate journal editors are thinking about this, so it can help us get some of our work published in the Blue Journal. So my charge was to talk about a few topics, which I will get into, and I know I want to leave some time for questions, so maybe I'll skip through some of the things that have already been covered. But you know, we're gonna talk about understanding research validity and pitfalls, statistical versus clinical significance, which was already discussed a little bit, common biases and pitfalls, selection bias, confounding, p-hacking, and publication bias. Causal machine learning, I think we will hopefully have a little bit of a discussion about that. The role of statisticians and why statistical expertise should be integrated early and an ongoing basis, as opposed to, you know, initially when you're sort of need help with the code, and then, you know, when you get the tables and you don't understand what the tables mean. It's really an ongoing relationship. And this is something you should be asking for when you're looking for a mentor, that do they have a statistical expert on their team, because that's really going to inform the work that you are going to be doing. So, you know, internal validity is, it refers to the extent to which a study's results are truly due to the exposure or the intervention and not influenced by confounding factors. And there are several key threats that are listed here, including selection bias, where differences between groups affect outcomes, information bias or misclassification, and confounding factors that we've spent some time talking about that distort true associations, and the lack of randomization or blinding, which can introduce systematic errors. And so to mitigate these threats, we focus on strong study design, as Jeremy has already talked about, with randomized control trials being the gold standard, followed by cohort and case control studies, and additionally using standardized checklists like Consort for randomized control trials and Strobe for observational studies really help ensure methodological rigor and transparency. So, you know, this here, as I've given you, evaluates a new blood pressure medication in an RCT to determine if it is more effective than an existing drug. However, internal validity can be threatened by several factors. So, you know, how does selection bias, for example, play a role? It occurs if a healthier patient is more likely to be assigned to the treatment. In addition, if you have information bias or misclassification where people can't recall data, it can also really cause problems, or blood pressure is measured inconsistently. So if you have somebody that's blood pressure is checked in the morning for some of the patients or participants, and then some are getting their blood pressure checked in the evening, or methods of checking the blood pressure. So confounding happens when external factors like diet or medications or other medications that the patient is on or the participant's on is really not accounted for. And then, of course, a lack of randomization and blinding can really introduce significant bias, as we know with observational data. So to mitigate these threats, of course, whenever possible, you should do an RCT, but we know they're costly, they're time consuming, you need to wait for a long time, especially in my space, for cardiovascular outcomes to occur. So it's not always feasible, but that's sort of the gold standard, as I mentioned. And then using objective measurement tools, blinding, randomization, and then standardized checklist. So as I said, consort for RCTs and stroke for observational studies really help ensure methodological rigor. So hopefully you're thinking about some of these things as you're looking into your study design and how you're going to mitigate some of these strategies. So I'm going to skip this slide, but just look at these sort of websites if you want more information on this, but in the interest of time, we will skip this. So we talked about internal validity. What's external validity? So external validity refers to the extent to which study findings can be generalized to other populations. And several factors impact generalizability. And I think Sanjay touched on this in terms of the external validation. So first, sample representation is crucial. If your study population does not reflect the broader patient group, so for example, you were studying obstructive sleep apnea patients who are non-obese, you know that our clinical practice typically our obstructive sleep apnea patients are obese. So the findings may not apply universally. Inclusion-exclusion criteria can also limit generalizability if they overly restrict who can participate in the study. Differences in healthcare systems, a VA versus Mount Sinai Health System, very different patient populations. So a lot of these factors are important for us to think about when we're looking into how applicable are our research results. And lastly, something that's important to me is, as I'm increasingly thinking about this, is the real world applicability versus the control settings of randomized controlled trials in the obstructive sleep apnea cardiovascular disease space, right? That's really an important consideration. Studies conducted in highly controlled environments may not reflect how treatments perform in everyday practice. And that may be what we're seeing with some of the RCTs in the OSA CVD space. So traditional statistical methods have limitations, as we've talked about, particularly in randomized controlled trials and observational studies, which are sort of the bulk of the data that most of us are working with. So RCTs, while considered the gold standard, have limited generalizability, as I mentioned, because they are conducted in controlled settings, strict inclusion-exclusion criteria. This means participants often differ from the real-world patients in terms of age, comorbidities, access to care, adherence to treatment. Additionally, RCTs assume static interventions, right? While the real world treatments are evolving dynamically, right? So you have new drugs that come out, whereas an RCT that was done 5-10 years ago, it doesn't really have the ability to evolve like the real world does. They also have limited scope, focusing only on the primary hypothesis with limited sample size and power for secondary analyses, and we see that. Observational studies face challenges as well. Many lack the sample size and diversity necessary to infer causality. And a major issue is unmeasured confounding, right? So we've talked about confounding a lot, and hopefully I'll leave a few minutes to talk more about that. But really, traditional methods rely on known covariates, but fail to account for hidden biases that could distort your results. So unmeasured confounding I think, is probably one of the key problems with observational studies. And if you don't account for it, or if you don't understand or don't have domain expertise to know what a confounder is, really some of the studies are going to be problematic, especially the results. So machine learning, I think it was mentioned a little bit, in artificial intelligence, combined with real world data, offers significant improvements in generalizability compared to traditional methods, in my opinion. First, AI-driven models enable trial emulations by leveraging large real-world data sets, including electronic health records, claims data, and registries to mimic clinical trials. These approaches enhance causal inference using techniques such as propensity score matching, which we've seen in the SAVE trial, and synthetic control arms, reducing potentially bias and confounding. AI also supports adaptive learning, continuously updating models with new patient data to ensure that findings remain relevant over time, as I mentioned, unlike RCTs, where real-world data sets capture diverse, scalable populations, making results more applicable across different demographics. So for example, we have 4 RCTs in OSA and CVD, but really when I'm sitting across a patient, I'm still not able to tell them whether or not CPAP is going to improve cardiovascular outcomes because, there are so many other factors in the real world. Additionally, integrating AI-driven insights into clinical decision support systems allows for real-time guidance, again, helping clinicians make better informed decisions for treatment for OSA. Moving forward, I think we should advocate for integrating ML and AI into clinical research, because I think that the real world data is really just waiting, especially electronic health records. So I'd love to see how we can do that. I'm going to skip on this slide in terms of the p-value, and I think Sanjay covered this a little bit, but statistical significance and clinical significance are different. So clinical significance, you could have, say, for example, like hemoglobin A1C is reduced by 0.2%. It's highly significant statistically, but what does it mean clinically, right? Like, how do you explain that to your patient? What does that mean? So always think about a statistical significance versus clinical significance. And then ethics and the consideration of ethics in interpretation is extremely important, right? So first, transparency and reproducibility are essential. Researchers must clearly describe their methodology and, when possible, share data openly to allow others to validate findings. And luckily, a lot of the RCTs, we have access to the data, and that's really great, but it's ideal if we can do that in almost every setting. Second, the misuse of statistics is a major concern. So practices like p-hacking, where multiple comparisons are run until a significant result is found, or failing to correct for multiple comparisons, can lead to misleading conclusions. And we see that a lot, unfortunately. And then, also finally, researchers have a more responsibility to report findings honestly and avoid making exaggerated claims, because scientific integrity really depends on these principles, because you may actually guide patient clinical decision making based on spurious results or over exaggerating your findings, which can affect patient safety and also treatment efficacy. So important things to keep in mind. I'm going to skip through this example for p-hacking and multiple comparisons, just in the interest of time. Selection bias, I think confounding variables we've talked a lot about, so I think I'm going to skip, and I think we should have a discussion about it. Let's see. So this is something maybe I'll spend a little bit of time on. So traditionally, epidemiologists pre-specify confounders based on prior knowledge and adjust for them in statistical models. And this approach has been the standard in observational research for decades, as was already pointed out by both of the prior speakers. I find that there are several challenges with this method. First, it requires domain expertise to define confounders upfront, which introduces some subjectivity, right? So what Sanjay thinks is a confounder and what he knows about the domain expertise may be different than what Jeremy knows or has had time to research before he started his project than mine. So I think there's always a little bit of that gray zone. Second, there's always a risk of missing unknown or unmeasured confounders, leading to residual confounding. And lastly, traditional methods struggle to account for complex nonlinear interactions between variables, which may influence the results. So as an epidemiologist in training, when I did my master's in public health at Yale, I always found it strange that I had to know about every confounder and decide which variable was a confounder, draw the DAGs, and then include this in my modeling. And I did it, and we still do it. But to me, it seems like there should be a better data-driven approach for this, where the machine can then identify, based on knowledge and the use of AI and the whole wide world that's out there, what are the potential factors that are confounders, that are maybe colliders, that are maybe mediators, and how can we devise a sophisticated way to do that? And I think the solution may be in causal inference techniques in machine learning. And we don't have time to go into this today just because we only have 2 minutes left. But really, that's what my lab and Orrin Cohen, who's on this call, and a lot of us are trying to figure out, is how do we bring cutting edge causal machine learning that handles confounding more robustly, and also helps us identify colliders that we should be ideally not including in our models. So causal inference is important, but I also want to specify the importance of machine learning, where you may not always need the causal inference, right? As I think Sanjay mentioned, if you apply traditional machine learning, you will still identify important predictors for your outcome. And maybe those predictors were hidden, were never thought of before. So it gives you a pathway for further exploration, but of course it could lead you into the wrong direction if you are exploring spurious variables that have just come up. So I think there is an important dialogue that needs to happen in terms of how we can apply big data and machine learning and causal inference in the right way, the right setting, to move us away from I think the way that I was trained to do, and really it seems to me like there has to be a better way to do it, just because of the reasons I mentioned. Publication bias, as mentioned, is, we know about this. Underreporting of negative or null results happens all the time. And recognizing, addressing conflicts, as Sanjay has mentioned early, right? Like a lot of my line of investigation has been using the data that I published, where obstructive sleep apnea does not seem to be universally harmful, but of course that's it's mostly data based and data driven, but there is a little bit of bias. So I, as an investigator, have to be aware of that, and I think most of us have to do that. So we have to address our conflicts, our biases, and ensure that the scientific rigor is not compromised. So key takeaways, and I apologize for speaking fast, but I just wanted to get through this. You ensure internal, external validity. Statistical versus clinical significance is an important piece. Ethical research practices, we discussed common pitfalls to avoid, specifically confounding and p-hacking, where you run multiple tests and report the one that you found is significant. That's a no-no. And then integrating causal machine learning and moving away from sort of the manual confounder selection. If I can find a way to do that using data-driven causal inference, I'm always looking for that. So to conclude, to calling the statistician after the experiment is done may be no more than asking him to perform a postmortem examination. And I'll leave you with that. Here's my email. If you have questions, please feel free to reach out.
Thank you so much for all your presentations. We are right at the 1 hour mark, but in the interest of time and respecting everyone's time, we were hoping to open it up for questions if the speakers are open to extending it by a few minutes. Okay, perfect. I'll start with one question. Well, firstly, to the audience, please use the Zoom chat on your computer for any questions or comments, and we will read it for our presenters to answer. The first question is, how can time-constrained healthcare professionals efficiently assess the quality of a study without reading every detail? And I'll open that to the three speakers.
I mean, I could say, I think one thing that helps is, again, look, like Sanjay said, looking at the journal, looking at the authors. I want to be open to anybody that wants to publish something, but if you see that this is coming from a reputable journal, coming from a reputable group that's published in the area, they've got the appropriate domain and methodologic expertise, I think that changes your pretest probability that the results of the study may be valid. That said, the flip side of that is that they may be more wedded to their hypotheses about things. But I do think that's an important thing to sort of look at. And then again, I think, does this pass the sort of sniff test, right? I mean, all the people on this call are clinicians. And if something really seems that it's just really way out of left field and it doesn't make sense, sort of clinically, I'm not saying it's not valid, but that might make me more inclined to really try to understand where that came from.
Thank you. I have a question for the group. So, as we said, a lot of us are clinicians and novices at critically appraising research works. Do you have any resources or tools? I think you may have briefly touched on like standardized checklists to utilize when we're evaluating RCT or observational studies. Can you speak more about that?
So I think Neomi had that. I don't know if Neomi want to comment on the consort and stroke.
Elaborate a little bit more on the use of like a standardized checklist when you're going through a study to try to critically appraise it and determine its value.
Do I use a standardized checklist? Is that the question?
Do you think they're helpful for using? Especially for us who, I guess, aren't used to maybe that thought process of critically going through a work to look for bias and things like that.
Yeah, I mean, I think what Sanjay said is what I use. The principle is like, if I'm looking at a journal where I know the authors, I know who's like the gatekeeper, and I know that they have robust statistical expertise reviewing this, I am less likely to have that lens on. But if I'm looking at an article from a journal that doesn't have that reputation, then yes, then I'm looking to see their method section, for example, how did they define variables? Because often I find that, as an epidemiologist, how they collected smoking varies across, right? It could be yes, no, it could be ex-smoker for, current smoker, it could be pack years. And then how did they include that in their model? Were they using continuous variable? Did they dichotomize? Or did they lose power? So I do more of that when I'm dealing with a paper that, for example, is not from like the New England Journal or the Blue Journal or Annals. So yeah, it really depends on the author and the journal. But I don't have a checklist specifically. I just go through the paper systematically and look at every single aspect that we've discussed.
I guess I would say for someone who's junior who hasn't done a lot of research, I think the checklists are really helpful, especially the consort one for trials, in just having right having all of the aspects of what should be in a randomized trial in front of you. I think what's important though is that you not just think of it as a check mark. Yeah, they said they explained how they allocated or whatever, but you actually read what they wrote and say, does this make sense? Do I agree with what they've done here? The strobe is a little bit more complicated because there's such a wide variety of observational designs that a lot of the things on the strobe checklist are not going to be applicable for any given study. And so it can get a little overwhelming to look at all of the, 57 things in the strobe. But
Okay, thank you. I'll end with one last question. This is from Dr. Cohen. He'd like to hear a response from Drs. Patel and Orr on Dr. Shah's comment on data-driven approaches to identifying co-founding.
Sanjay, you want to?
I guess I am not as knowledgeable, I guess, of what the cutting edge research is here. So I guess I just have a big question of how you can distinguish a confounder from a collider using a pure data-driven technique. But I guess, I don't know, Neomi, and again, I'm not aware of this. This is Neomi's research interest, so she may know a lot more about what's been done there.
Yeah, and I would just say, I think for the purposes of most studies, I think the biggest issue that I see are a lack of really clear rationale for covariates that are included as confounders, and for sensitivity analyses and other things that might help to, look at the robustness of the assumptions about the pathways and the causal structures. So that's what I think. Again, I'm not an expert in causal machine learning by any stretch of the imagination, but I would say even before we get to that, we have a long way to go in terms of a lot of articles and what they actually assume, and a lot of it is not made real explicit. I would love to see more use of directed acyclic graphs, for example, in papers. It can be in the supplement, that's fine, but that really helps to lay bare what the assumptions are about the causal structure of things. And I think then if we want to go beyond there and say, we think that we're missing things, we think they're unmeasured confounders, or that these things aren't really confounders, they're mediators, etc. I welcome, progress in that area.
Yeah, I just one last comment on that. I think that that's important to see that. I guess my question would be to all of us, right? Like if you are a clinician and not working with DAGs and you're reading a paper, how do you make sense of a DAG? As a researcher, as an epidemiologist, DAGs are repulsive to me. I don't like them. So I guess my question is, how do we challenge ourselves where we're at the intersection of statistics, advanced statistics, machine learning, and as epidemiologists? How do we bring something that is, of course, scientifically robust, has to be, but can also be not based on, sort of domain expertise, right? if I want to work in spaces that I haven't worked in, for me to then be aware of every single DAG confounder, it just to me seems archaic, for lack of a better word. And I think that's where Oren and I, we spend a lot of our time talking about this, being fully aware that the causal inference piece needs to be ironed out and done well, but that's the challenge we're facing currently. So Jeremy, your talk really was helpful in probing us to think deeper about this, but maybe even developing machine learning models that can actually show you a DAG, right? But I don't know how you would do that for 2,000 variables, 10,000 variables, right? You just when the data set gets very large, how do you do this? And I think that's the challenge. But
Yeah.
I know we're out of time, so.
Yeah, I think that's a super interesting area, and look forward to what you guys come up with. I just, what I think still happens is that we put the cart before the horse in that, trainees learn statistics before they learn about causality and causal models and causal inference. And so I would encourage everybody on this call, if they really want to understand the literature, I think you really have to understand, how we conceptualize causality. Because again, most of the things that we really care about aren't the prediction models as much. I mean, it's usually trying to understand cause and effect. And so, to learn about DAGs, to learn about those things is as important, if not more important than understanding, if you fit a linear model, with least squares versus, maximum likelihood or something. I mean, that I don't think is as important, I think, but the causal structure of things, the assumptions that we're making, are really, really important.
Yeah, but I think in order for us to sell this concept, we will have to make the case of what is the importance of learning how to spell complicated words in the era of autocorrect and ChatGPT, right? Like the new generation is going to ask you that. So I think that's the hat I'm putting on is, yes, it's extremely important, but if you have a data-driven approach that identifiers out of the 200,000 variables, these are your confounders, these are your colliders, these are your mediators, so the question is like how important it is. I think it is. I'm not suggesting it isn't, but I think we need to find a way to talk in those terms so that people are interested in learning, especially as we move into that space. But this is really a great session, Melissa. Thank you so much, and Sonal, and all of your organization, like your emails, like how early you started planning this, really robust, really well done, and I appreciate the opportunity.
Well, on that, I would really like to thank all of you guys. On the behalf of the ATS SRN Education Subcommittee, Melissa and I would like to thank our speakers. They have been wonderful. Dr. Jeremy Orr, Dr. Neomi Shah, and Dr. Sanjay for their excellent presentations. And of course, thank you to our listeners for joining us today. I hope everyone enjoyed this session and hope everyone has a wonderful day.